Now, the last question. So again, any doubts, please let me know. Then I'm talking about the management of endometriosis. Okay, so in management of endometriosis, you have, first I'll talk about the general principles, then I'll talk about non-surgical management, then I'll talk about surgical management. Okay, and then we have to talk about GnRH uses in gynecology. Again, a very beautifully made answer, very nicely made answer. So let's start with the general principles of management. So what do you see whenever a patient comes to you with endometriosis? She comes to you either with pain or she comes to you with fertility, right? So to relieve the pain or improves the fertility. These are your two main aims. Tailor the treatment to patient's symptoms, fertility desires, and lesion type. Consider multidisciplinary approach, especially in case of deep infiltrating endometriosis. Okay. Then you have non-surgical management. So first of all, what will you try? You'll try NSAIDs for pain, COCPs, POPs, right? Second line is progestins, GnRH agonists and antagonists both. And certain HRTs, if at all you have this requirement for this thing, if you already entered the menopause, and probably an HRT management. Then surgical resection like laparoscopic excision, ovarian endometrioma surgery, deep infiltrating endometriosis surgery, and hysterectomy with BSO if required. So wait. So this is basically the management of endometriosis because that was asked. Okay, so you first see what the patient wants. So you're going for lifestyle management, decreasing stress, proper diet, less of junk food, more of exercise, more of stress management, and cognitive behavior therapy required. And then going for a proper medical management. If it's not getting at it, then go for a surgical management. Okay. Now I'll start with GnRH agonist, antagonist in the management of endometriosis. All right. So first of all, in the management of endometriosis, correct? Wait, I'll have to. We were talking about, yes. See, when GnRH agonists, they come, the management of endometriosis, we can talk about GnRH agonists and antagonists like this, that they cause an initial flare, and that's caused by, and that's followed by downregulation. And when you talk about antagonists, they cause an immediate GnRH block, and there is no initial flare up. Okay. So when you're talking about, inducing or stimulating ovulation in patients with PCOS who have a very high chance of development of OHSS, you do not take agonists. You strictly start from antagonists. Okay, and of course you take 3 to 6 months. Here you take up to 24 months. Okay, and you do need therapy over here, and might not require over here. Okay, and here you have certain side effects like menopausal symptoms. Here you have fewer hypoestrogenic side effects, but you still require HRT. Whenever you're using these agonists, antagonists, guys, you will require a add-back therapy. So no matter what they say, you please always mention the HRT. Okay, and here you require add-back therapy is required if you use it for more than 6 months. Here it is required if it's for long-term use, more than a year or so. Correct? So you do require HRT anyways. So when you are having an endometriosis, fertility as the main consideration for endometriosis management, then you go in for ovulation induction, IVF, endometrioma drainage, laparoscopic surgery. Many times they say that if you do not remove endometrioma for a patient with endometriosis, you might not be able to achieve proper embryo, proper ovulation, stimulation, ovulation induction, and proper ova. You'll not be able to get that, right? So you're going for a proper laparoscopic surgery, you're going for endometrioma drainage, you're going for a embryo transfer. Then you're going for a long-term management or recurrence prevention with the help of hormonal suppression, lifestyle modification. So still I'm talking about management of endometriosis only. Okay, so I spoke to you about, in short, about the non-pharmacological methods and pharmacological methods. Then I talked about hormonal methods. Then I talked about surgical method, and then I spoke a little bit about GnRH, agonist, antagonist, the management of endometriosis, and then I'm talking about long-term management and recurrence prevention. So basically, you're going for a hormonal suppression, lifestyle modification, regular monitoring, regular follow-up, and that's it. Okay, guys, so that was the management of endometriosis with the help of so many things that we spoke about, right from non-surgical, medical, to hormonal, to second-line medical, to surgical management, to the role of GnRH agonist and antagonist, to fertility considerations including ovulation induction, IVF, to surgical fertility management, okay, to long-term management, and now we are coming to GnRH uses in gynecology. Another very exhaustive, very long answer. So basically, we'll talk about the mechanism of GnRH analogs. What exactly are these analogs doing? Okay, so they can act as agonists also, they can act as antagonists also, and you have, when I'm talking about GnRH, I never mentioned agonists and antagonists, so I'm using both. So as far as agonists are concerned, they cause an initial increase in FSH and LH, a flare effect, like I just spoke to you. That's followed by a downregulation or suppression. So what do they do is that they lead to a hypoestrogenic state, which is beneficial in conditions which are reliant on estrogen, for example, in endometriosis. Okay, guys. So when we were talking about GnRH agonist, do you see this table? So you see that it causes initial flare-up followed by downregulation, and there is a continuous suppression of ovulation. So what they do is basically they are very good for, they lead to a hypoestrogenic state, which is beneficial in conditions that rely on estrogen, which is why you have a lot of support by GnRH agonists in endometriosis, adenomyosis, fibroids. And then comes GnRH antagonists, which block the GnRH receptors immediately, and there are no initial flares. So there is rapid suppression of FSH and LH. Okay. So the clinical application of GnRH analog is endometriosis, uterine fibroids. Okay, and even adenomyosis. That thing should have been written over here only somewhere. But yeah, definitely endometriosis. I'll write down. Okay. So, correct. This is number 3. All right. If you remove this will look okay. Now, then you have PRT. PRT is another place where you have GnRH agonist and antagonist use, isn't it? In controlled ovarian stimulation protocols, isn't it? GnRH antagonist used to prevent premature luteinizing hormone surge during controlled ovarian stimulation, and you have down regulation protocols. I have taken a huge lecture on the different protocols used. Okay, GnRH agonist, antagonist being used, long acting, short acting, everything I've used, and I've made a whole lecture. See, short antagonist protocols may reduce OHS's risk, isn't it? I just told you regarding that. And long-acting GnRH agonists are used to prevent premature ovulation. So basically, those people with POI, they act very well with GnRH agonists, but GnRH antagonists are used for those like PCOS, in which there's a huge risk of OHSS. Then you come to precocious puberty. It can be given again as a treatment of choice to delay the puberty in children with central precocious puberty. Then with menopausal symptoms, breast cancer treatment. Hormone-sensitive breast cancer suppresses ovarian estrogen production. Okay. Then gender-affirming hormone therapy is also used. So here I have a whole table for you again for the different applications of GnRH agonists and antagonists. Okay. Yeah. So endometriosis, uterine fibroids, adenomyosis, IVF, precocious puberty, breast cancer, gender affirming. Okay, and then a few skipping slides like monitoring the effects and menopausal symptoms and routine follow-up, and that's it. So I put the last slide in front of you so that it's the most take-home message for GnRH agonists and antagonists. And now I'm ready for your questions, guys. So if you have any, you can ask me. And otherwise, you can log off and enjoy your Sunday, all of you. because we're done with the 10 questions that were asked. Very vague questions, some of them were, but I've tried to do justice by including as much as possible through whatever tables I could get, whatever material I could get, and whatever I thought possibly could be a question. So that obviously when the question bank will be, the actual questions will be released, I'll probably have to modify these answers accordingly, right? But till that time, please make peace with these answers, and they're very, very, logically, thoughtfully made answers. So please, and especially the tables, it requires a lot of effort to make these tables, guys, and they are all summary tables for you. So go ahead and learn from these tables, and some of them, only the tables are sufficient. Okay. All right, guys. Any carcinomas follow-up always is 3 monthly for the first 2 years, 3 to 6 monthly in the next 2 years, and annually for the remaining 5 years for all of them. Okay? And every time the patient comes to you for a CA ovary, you do a clinical examination, you do a CA 125 check, and you do a TVS. Okay, that's how you manage the follow-up. Okay. Anything else, guys? Anything else I can help you with? Any other question? Okay, wait. So I'm stopping the recording.